All right, good morning, everyone. Happy March 30th. We're here today for our McMaster St. Joe's Hamilton Health Sciences Citywide Medical Grand Rounds. I'm Dr. Madeline Verhovsek. I'm the Chief of Medicine here at St. Joe's. Next slide. And we're delighted to be the host site for today's rounds. Next slide. We'll start with a land acknowledgement. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Next slide, please. And it's my honor today to welcome our trio of co-presenters. We have Dr. Arman Zereshkian, Dr. Laura Spatafora, and Dr. Rachel Gerber, who are going to be presenting on the topic of immune checkpoint inhibitor toxicities in the ICU, a review. It's going to be a really fascinating presentation. And I'm going to hand things over to Dr. Amanda Huynh, who is our CTU director here at St. Joe's, and she'll provide further introduction to our presenters. Over to you, Dr. Huynh.
Thank you so much. So I have the pleasure of introducing Dr. Rachel Gerber. She is a PGY3 in internal medicine here at McMaster, and she will be pursuing a fellowship in rheumatology at the University of Toronto. Dr. Laura Spatafora is also another PGY3 in internal medicine here at McMaster, and she will be moving on to pursuing a fellowship in critical care at the University of Toronto. And Dr. Arman Zereshkian is a PGY3 in internal medicine at McMaster and will be pursuing a fellowship in medical oncology at the University of Toronto. So welcome. Excited to hear your talk.
Thank you. Thank you for that introduction, Dr. Verhovsek and Dr. Huynh. We have no conflict of interest to declare. Next slide. So our objectives for today are to review the backgrounds of immune checkpoint inhibitors, their current use in oncology, the mechanism of action of immune checkpoint inhibitors, types of adverse events and toxicities, and how we care for these patients when they present with toxicity in high acuity settings. So that's both level 2 and level 3 critical care units, what the prognosis is for patients who develop this toxicity, and the considerations for Rechallenge, and we'll leave a few minutes for discussion and questions. Next slide. So I'm going to start off with two clinical cases to kind of frame our discussion. The first case is a 57-year-old gentleman with metastatic papillary renal cell carcinoma who's currently on combination immune checkpoint inhibitor or ICI therapy with ipilimumab and nivolumab. And he only received one cycle before he presented to the emergency department with progressive diplopia. On exam, his blood pressure is a bit elevated, but his heart rate is fairly normal and his O2 saturation is normal on room air. He's afebrile. On clinical exam, he has bilateral fatigable ptosis and some difficulty with clearing secretions, and there was also a note of dysphonia. His features are felt to be clinically consistent with immune checkpoint inhibitor-mediated myasthenia gravis, and your thoughts should be, how do we manage this patient? Next slide. The second case is of an 83-year-old gentleman with metastatic renal cell carcinoma as well, who presents to hospital after second cycle of nivolumab monotherapy with abdo pain, right-sided facial droop, and diffuse weakness. His troponin is found to be elevated with an ECG that demonstrates ST elevation. He has an urgent CT head performed, which was unremarkable, and an urgent echocardiogram that shows a left ventricular ejection fraction of 30% with small pericardial effusion and no regional wall motion abnormality. He's admitted to the cardiac care unit while awaiting angiogram and cardiac MRI. So you should think of what your differential diagnosis is for this patient and how we would manage this patient. Next slide. So the key guidelines for anyone who wants to learn more about immune checkpoint inhibitor toxicities, there's the American Society of Clinical Oncology Practice Guidelines published in 2021, or the ASCO guidelines that you can review. There's also the ESMO, or European Society of Medical Oncology Clinical Practice Guidelines that were just published in October 2022, so fairly recent that people can review. Next slide. So to begin off, to just kind of have a discussion around this. So immune therapy, or the idea that our white blood cells or our immune system has a role in targeting cancer cells really goes back to Rudolf Virchow in 1863 when he looked under the microscope and saw there was a lot of inflammation and leukocytes that were coating tumor cells. But it wasn't until around 1891 where a physician by the name of William Coley actually put this kind of to the test, where he took inactivated Streptococcus pyogenes and Serratia samples and actually injected them into patients with sarcoma and found that there was some benefit. And because of that, he was the first one to kind of think about, well, how do we prime the immune system? He's been often touted as being the father of immunotherapy. I think the reason why I have this slide is because immunotherapy is more than just immune checkpoint inhibitors. It also encompasses oncolytic virus therapy, where we genetically modify viruses to cause a pro-inflammatory state within tumor cells. There's also cytokine therapy, such as interferon or interleukin-2 therapies that were predominantly used before immune checkpoint inhibitors for the treatment of melanoma and CML. Cancer vaccines that also cause a T-cell reaction that are used in prostate cancer are still used today. And then there's adoptive cell transfer, such as chimeric antigen receptor T-cell therapy or CAR T-cell therapy that many have heard of, that is up and coming and being more commonly used in hematologic malignancies. But that too is also a form of immunotherapy. But for our talk today, we'll just be focusing on immune checkpoint inhibitors. And so we can go to the next slide. So I think one of the things that a lot of us forget is that immune checkpoint inhibitors have only been on the market for the last 12 years. They were first approved in metastatic melanoma in 2011, so very new drugs. And as I said, they were initially started in approval for metastatic disease. And it was monotherapy. So they haven't been on the market for that long. Next slide. But as you can see from this slide, when it was first approved in 2011, and then there was approval of other immune checkpoint inhibitors, there's been a massive explosion of these drugs being used in oncology today. First, it was in melanoma, and now you can see on the y-axis, they're being used in so many different malignancies. And as you can see on the x-axis in 2020, there's so many different formulations that are now available. And there's more coming each day. And this is really a rapidly evolving field. Next slide. This is a 2022 review that shows FDA-approved immune checkpoint inhibitor approvals. So you can see for the indications that it was melanoma in 2010, 2011. But now we use immune checkpoint inhibitors predominantly in the metastatic setting, so in stage 4 cancers, in non-small cell lung cancer. We use them in urothelial cancers as well as renal cell cancers and other bladder cancers. But there's increasing role for them to be used even in breast cancer as well. And there's increasing indications every day. Next slide, please. What was interesting was there was a study done out of the University of Toronto in 2021 looking at the uptake of immune checkpoint inhibitors in advanced cancers in Ontario. And if you look at the last column of this table, overall use when it was first approved was about 3%. But if you look at 2019 in the last column, about 40% of patients are now receiving immune checkpoint inhibitor. That's a huge difference in the span of 10 years where they went from being just one drug to many drugs, but now they're being used even more commonly. And I would actually say that 2019 figure of 40% is probably out of date. It's probably closer to 50%, but there needs to be more data collected around this. Next slide. And if you look at this table where it's looking at the proportion of patients who go to receive immunotherapy on the y-axis and the year of diagnosis, you can see for indications of melanoma, kidney cancer, as well as lung cancer, there's been such rapid increase in uses where before less than anywhere between 10 to 15% of patients were using them to over 60% of patients using them. Next slide, please. So a lot of questions we get asked are around prognosis of patients. This is just a very small table of what long-term outcomes look like. So for example, the Checkmate 67 trial, which was actually looking at combination immune checkpoint inhibitors versus single, showed an improved 5-year overall survival. But the details of this slide are less relevant as it is to show that 5-year overall survival is significantly improved when patients use immune checkpoint inhibitors, either as dual immune checkpoint inhibitor or in combination with another chemotherapy medication. And the same kind of pattern is really seen in patients who are using these drugs for non-small cell lung cancer as well. Next slide. So far, I've only been speaking about immune checkpoint inhibitor use in patients who have stage 4 metastatic cancer. But in the last 2 to 3 years, we've really seen immune checkpoint inhibitors taking a stronger role in the treatment of earlier stage cancers, either in the neoadjuvant or adjuvant setting. For example, there's current approved uses for neoadjuvant immune checkpoint inhibitors in patients who have a triple negative breast cancer. So that's not metastatic disease. These are people who are going for curative intent, for advanced non-metastatic melanoma and even non-small cell lung cancer. There are ongoing trials as we speak in bladder cancer, breast cancer, gastric cancer, and also renal cell carcinomas. And I think the relevance of this is because you as clinicians who may actually end up admitting these patients in peripheral hospitals, you should just remember that immune checkpoint inhibitors aren't just being used for metastatic disease anymore. A lot of the patients are using them for curative intent. And that's just something to keep in mind when seeing patients who present with these toxicities.
All right, so I'm going to get into the mechanism of action of immune checkpoint inhibitors. So immune checkpoint inhibitors block anti-tumor activity by blocking intrinsic downregulators of the immune system. So some examples of what they target are CTLA4, PD-1, and PD-L1. Normally, what these regulatory receptors do is they maintain a balance between T cell activation and T cell inhibition. But by blocking these molecules, they'll neutralize the checkpoint, allowing for T cells to have ongoing activation and therefore ongoing anti-tumor activity. So this is just a picture describing what I'm talking about. So on the left, you can see this is an example of CTLA4. So typically what happens is CTLA4 binds to CD80-86. I'm not sure if you can see my cursor or not. And what that does is that inhibits the T cell function. But when you add in an immune checkpoint inhibitor, as you can see here, that blocks the binding of CTLA4, therefore allowing the T cell to have ongoing activation and ongoing anti-tumor activity. And a very similar process happens here with PD-L1, PD-L2, and PD-1. So these inhibitors block these molecules, allowing the T cell to have ongoing activation. So unfortunately, when we do this with the immune system, it can also lead to some undesirable immune and inflammatory events. So these are called immune-related adverse events. And the most common ones are rash, colitis, thyroiditis, hepatitis, and pneumonitis, as well as arthritis. But as you can see here on the picture on the right, it can affect almost every organ system. And the other thing to note is that individuals can often have more than one immune-related adverse event at the same time, affecting multiple organ systems. So the common terminology criteria for adverse events is what is used most commonly for grading severity of these adverse events. So grade 1 is mild or asymptomatic, often not requiring intervention or treatment. Grade 2 is moderate, so with minimal symptoms requiring sort of local or non-invasive treatment. Grade 3 and 4 are more severe, often requiring hospitalization, ICU admission, and urgent intervention. And grade 5 is when a patient has died due to these adverse events. Later on in the talk, Laura will go on a little bit more about how this will help guide treatment of immune-related adverse events. So there are many risk factors which are related to these adverse events. They are often divided into these three categories: patient-specific, tumor-specific, and antigen-specific. So the patient-specific risk factors include demographics such as age, gender, so men more commonly in PD-1 and PD-L1, and women more common in CTLA4. Medical history such as autoimmune diseases, allergies, cardiovascular disease, chronic kidney disease. If individuals are currently taking medications such as PPIs, NSAIDs, diuretics, ACE, and antibiotics. And then the tumor-specific risk factors are if an individual has higher disease burden, such as metastatic disease. And then there are other adverse events that are specifically related to types of cancers, so such as melanoma, which is at higher risk for colitis, and dermatitis and hepatitis, which occur more commonly in AML and MDS. And the third category for risk factors are antigen-specific categories, so CTLA4 inhibition, PD-1 inhibition. And I think almost most importantly in this category is combination therapy. So it has been found that individuals that are on 2 or more agents are more likely to develop immune-related adverse events. So just a quick note on pre-existing autoimmune disease. From the research we've done, it seems as though patients with autoimmune disease are often not offered immune checkpoint inhibitor therapy. And this is out of concern for exacerbation of their symptoms, or if they're well controlled, a flare of their symptoms. And they're often excluded from these clinical trials. However, data does suggest that these patients can be safely treated with immune checkpoint inhibitors. One study that we looked at found that 40 to 50% of patients will report disease flare. And this was a study that included patients with pre-existing rheumatoid arthritis, psoriasis, and psoriatic arthritis. And it seems as though the patients that do develop a so-called flare, the flare often isn't bad enough to even discontinue the immune checkpoint inhibitors. So they often do continue through therapy. So the occurrence of these adverse reactions, time to onset and time to resolution, remains unclear, but there are many factors which are associated with this, including the type of cancer, as I mentioned previously in risk factors, the type of treatment, so CTLA-4 and PD-1 or PD-L1, the treatment dose of these inhibitors, as well as pre-existing risk factors. Most adverse events do occur within the first 3 months of therapy. However, they can occur at any time, even years after discontinuation of immune checkpoint inhibitor treatment. And the time of onset can be acute or delayed. And for the purpose of the research in our presentation, delayed is arising after 1 year of treatment. And it does seem, though, that patients who do develop delayed adverse events have often reported an acute event earlier on in their treatment already. So this picture, I think, is a good representation of sort of what happens in the cycle. So on the top of the photo is patient risk factors, and on the bottom are tumor-related risk factors. So as you can see on the top, the acute toxicities occur very early on, and the chronic toxicities peak around here and then progress. For the definition for us, chronic toxicity is one that persists for greater than 12 weeks after discontinuation of treatment. And then the other thing to note here is that on the bottom where it says tumor-related factors is the need for rechallenge and tumor recurrence. So there are many factors that are involved in the need for rechallenge. Those who maybe developed acute toxicities earlier on and discontinued their immune checkpoint inhibitor may then undergo a rechallenge for these medications. Whereas those who maybe completed their immune checkpoint inhibitor treatment and developed some toxicity later on may not actually undergo rechallenge, but there are many factors involved in this. And so, as I said, chronic immune-related adverse events are those that are persisting 12 weeks after discontinuation of immune checkpoint inhibitor treatment. This picture is a good representation of chronic immune-related adverse events. The percentages here on the bottom right are the percentage of acute toxicities that are likely to become chronic. So as you can see here, the 80 to 100% are mostly endocrinopathies, such as hypophysitis, thyroiditis, hypothyroidism, and adrenal insufficiency. So it seems as though the endocrinopathies are more likely to become chronic as compared to adverse events of visceral organs, such as pancreatic insufficiency, diabetes, celiac disease, and esophagitis.
Okay, thanks, Rachel. So now I'm going to talk about the incidence and prevalence of severe immune checkpoint inhibitor toxicities and their management. afterwards. So first of all, it's important to note that at this point, we don't have any established clinical or diagnostic criteria for immune checkpoint inhibitor toxicities or immune-related adverse events. And this means that they can be challenging both to diagnose and identify, and likely their incidence is underreported in the literature. We do know that oncology patients constitute a significant proportion of patients admitted to ICU settings each year. And as of this international survey of ICUs in 2014, Vincent et al. Here, it was an estimated prevalence of or incidence of 12.1% of ICU patients were of the oncology population. And this is from 2014, so likely this number is also higher now. Multiple studies touch on this, including this retrospective review, Vigneron et al. 2021 in a French ICU, which demonstrated increasing numbers of cancer patients admitted to ICUs with increasing numbers of or percentages of admissions of patients with metastatic disease and increasing prevalence of oncologic drug-related adverse events and increasing proportion of patients using immunotherapies and other targeted therapies. Next slide, please. So here we have a table showing the incidences of some of the most common immune-related adverse events for immune checkpoint inhibitors. And at the top, we have it organized in terms of all grades of severity, grades 1 to 4. And then at the bottom, we have incidences for just the higher grades, grades 3 to 4. And this is illustrated from a 2017 systematic review of randomized clinical trials of immune checkpoint inhibitor therapy, looking at over 11,000 patients. Of the 21 trials included, I will note that none of them actually looked at toxicity as a primary endpoint. Next slide. Okay, and here we can see that when they actually compared patients who received immune checkpoint inhibitors versus any other control drug, they did find that immune checkpoint inhibitor therapy use was associated with a significant increase in severe colitis, severe hepatotoxicity, and at the bottom, when investigators excluded one trial that used everolimus as their control drug, this is a drug that's also known to cause pneumonitis. When they excluded that, they also found that there was a significant association with severe pneumonitis as well. Next slide. And lastly, there was also a difference when they compared between immune checkpoint inhibitor class. So they found increased incidence of high-grade colitis and rashes for patients treated with CTLA-4 inhibitors compared to PD-1, PD-L1 inhibitors. Next slide. And this is a nice visual representation. This is from a review of severe immune checkpoint inhibitor toxicities in the ICU setting. And I like it because it illustrates the incidence of various immune-related adverse events, comparing PD-1, PD-L1 inhibitors on the left side with CTLA-4 inhibitors on the right side. The size of the circles is directly proportional to the incidence of each toxicity. The blue color represents toxicities of all severities, and the red represents toxicities of grade 3 or grade 4, so the more severe toxicities. So we can see here the relative increased frequency of GI toxicities, both colitis and vomiting. I'm not sure if you can read the details there. In the CTLA-4 inhibitor patients, compared to on the left, where we see higher incidences of neurotoxicities, pneumonitis, and cardiac toxicities in the PD-1, PD-L1 inhibitor treated patients. Next slide. Of course, patients who are on immune checkpoint inhibitors can have multiple reasons for clinical deterioration requiring admissions to step down or ICU. Aside from the immune-related adverse events from these drugs, they may develop adverse events from other cancer treatments that they're on, such as chemotherapy or other immunotherapies. So consider the example of a patient with metastatic renal cell carcinoma who's on pembrolizumab and axitinib, which is a tyrosine kinase inhibitor. Both of these drugs can cause diarrhea and colitis. And so in this type of patient, determining the offending agent would be very important, both in determining how to manage the acute toxicity and, of course, further long-term in determining what their future cancer treatment options will be. As well, patients can decompensate as a consequence of direct progression of their tumor. Other malignancy-related complications, such as spinal cord compression, venous thromboembolism, tumor lysis syndrome, the list goes on, or illnesses unrelated to their cancer, such as common things being common septic shock, for example. Next slide. So as Rachel mentioned, immune checkpoint inhibitor toxicities are graded in that severity on a scale of 1 to 4, with 4 indicating the most severe life or organ-threatening complications. As per the 2021 ASCO guidelines and the 2022 ESMO guidelines, patients with moderate to severe immune-related adverse events should be admitted to hospital, and consideration of ICU admission should be considered for any patient with a grade 4 event or those with grade 3 events who appear to be worsening in their clinical status. In terms of treatment, so we'll talk more about steroids, but systemic steroids are the first-line treatment for all immune checkpoint inhibitor toxicities, and a course of pulse steroids is recommended for pretty much all patients with severe toxicities, and this is typically with a gradual taper over weeks to months. For those who have disease that's refractory to steroid treatment, we have a variety of biologic and non-biologic immunosuppressant agents, which are recommended in guidelines. Although I will note that the data on these immunosuppressant drugs is largely extrapolated from their use in other autoimmune diseases. And so we lack actual prospective data on their use in immune checkpoint inhibitor toxicity specifically. And so what their actual efficacy is and their potential harms is an area where we need further research and is somewhat unclear at this point. And then lastly, in the column on the right, we can see general recommendations as to whether or not you would be able to resume immune checkpoint inhibitor therapy after resolution of acute toxicity. Typically, this is a very nuanced conversation that requires involvement of medical oncology and potentially other subspecialists, but for simplicity, for those patients who have the most severe toxicities that require admission to ICU, more often than not, these patients will not be resumed on their immune checkpoint inhibitor therapy in the future. Next slide. Okay, so this is a sort of an illustration of what a general approach to a critically ill patient on immune checkpoint inhibitor therapy might look for. This figure is hopefully from a review in Annals of Intensive Care from 2019. So in general, it's important to have awareness of the broad clinical spectrum of potential immune-related adverse events. And this is essential in order to identify that this patient may have an immune-related adverse event and to ensure that patients with compatible symptoms are appropriately investigated for possible toxicities and considered for admission to a higher care setting, given their risk of clinical instability. Concurrent management can then be initiated while further investigations are undertaken to rule out other causes for their presentations, particularly infection or other undiagnosed autoimmune processes or flares of known autoimmune disease, and to characterize the current extent of both their underlying malignancy and of the toxicity. Immune checkpoint inhibitors and other potentially offending medications, such as other cancer-related medications that patients are on, should be stopped in the acute setting or held right away. And then pulse steroids should be started concurrently as patients are provided with ICU level support that they require, patient depending. So whether that's mechanical ventilation, vasopressors, renal replacement therapy, or even ECLS. The addition of second-line immunosuppressants would then be considered for treatment refractory disease, typically after 48 to 72 hours of steroids, and in collaboration with subspecialists such as medical oncology, rheumatology, and, for example, if it's a patient with severe pneumonitis, with respirology as well. I've included a couple of points on the left of this slide just to sort of highlight some of the important management principles to keep in mind. And I've already talked about the first two, but at the bottom I've mentioned goals of care conversations. So of course, this would be very important to have with our patients early on in anyone who is critically ill, but also as we start to identify the impact that an immune-related adverse event may have on these patients' potential to resume further treatment for their cancer and what this means for their overall prognosis from their underlying disease, which may impact what decisions they and their family make about the care that they wish to receive during their critical illness. Okay, next slide. So now we'll talk about the management approach to a few specific subtypes of immune checkpoint inhibitor toxicities. I'll talk first about GI toxicities. These are the most common, and their incidence is as high as 54% of patients who are on immune checkpoint inhibitors may expect to develop some sort of GI toxicity. In terms of the high-grade toxicities, this will typically present as a severe colitis and may include complications such as bowel perforation or toxic megacolon. Upper GI symptoms and pathologies that I've listed here, like duodenitis, gastritis, these are much less common. The workup for GI toxicities should include abdominal imaging with contrast CT. Typically, patients should have a colonoscopy, and biopsies are helpful to help rule out other etiologies, such as inflammatory bowel disease, and to look for infectious etiologies like CMV colitis. Additional investigations should be undertaken to rule out sources of infection. So these include stool studies, blood cultures, urine cultures, etc. Additionally, patients should be taken off of their immune checkpoint inhibitor and other cancer treatments in the acute setting, as I've mentioned, and started on pulse methylprednisolone with a slow taper, typically over 4 to 6 weeks. For those who are steroid refractory, the ASCO and ESMO guidelines typically recommend infliximab as the first additional immunosuppressant to add. And in those who continue to be refractory to treatment with steroids and infliximab, you can consider adding vedolizumab or tofacitinib. Sometimes in very severe cases, patients have required fecal microbiota transplant or even colectomy. Next slide. So now we'll talk about lung toxicities. The incidence here ranges from 1 to 10%, and the mortality rate can be as high as 14% as well. Patients who we should be particularly concerned about the development of ICI pneumonitis would include those with non-small cell lung cancer patients and those on anti-PD-1 inhibitor therapy. It's just more common in these patients. So pneumonitis can develop anywhere from 2 months to 2 years after treatment, and patients can progress to or develop ARDS. Clinical symptoms, however, and radiographic features are fairly nonspecific, and they can mimic other causes of respiratory distress like pneumonia. So typical symptoms include dyspnea, cough, fever, chest pain, and imaging findings can include ground glass opacities, reticulointerstitial disease, consolidations, organizing pneumonia, or NSIP pattern. These patients should have CT chest with contrast, PE protocol to rule out pulmonary embolism, as of course cancer patients have a higher risk of that, and infectious workup including blood, urine, and sputum cultures, viral NPS. And if the patient is stable enough, we should consider a bronchoscopy with BAL to assess for other infections that these immunosuppressed patients are at risk for. So that includes tuberculosis or PJP pneumonia. And then in addition to IV pulse steroids, the guidelines do recommend empiric antibiotic therapy, as it's just so difficult to distinguish between the immune-related pneumonitis versus pneumonia. So empiric antibiotics until cultures start to return and we can rule out infection. And then in steroid refractory disease, we can consider addition of infliximab, mycophenolate, cyclophosphamide, and IVIG. Of course, respirology should be involved fairly early for these patients. Next slide. All right, so I wanted to talk about neurological toxicities because they're very interesting. They encompass numerous different disease entities. So patients can present with Guillain-Barré syndrome, myasthenia gravis, PRES, neuropathies, aseptic meningitis, encephalitis, and demyelinating disease, anything from multiple sclerosis to neuromyelitis optica or transverse myelitis. The other thing about neurologic adverse events is that they are more likely to actually persist past the acute illness and for patients to develop a chronic toxicity that may be permanent. So that's really important also just for counseling for patients, of course. Workup should be tailored to the patient's specific clinical presentation and their neurological exam findings and differential diagnosis based off that, of course. But typically all patients will require brain imaging of some sort, CT, maybe MRI. Inflammatory markers can be helpful. And for many, consideration of lumbar puncture and perineoplastic workup is recommended as well. In addition to pulse steroids, treatment is also disease specific here. So for example, for myasthenia gravis and Guillain-Barré, we would still use Plex or IVIG as we would for idiopathic myasthenia gravis or GBS. But it's helpful to have neurology consulted early and to have their involvement in distinguishing if this is an immune-related adverse event or a disease caused by something else or idiopathic. One thing I'll note, for example, is that in Guillain-Barré, typically we don't use corticosteroids up front. We use Plex or IVIG, but in the case of immune checkpoint inhibitor associated Guillain-Barré, we would use corticosteroids up front. So this is just an example of where determining whether this is related to the immune checkpoint inhibitor is quite important and can be nuanced. And then I'll also mention that for myasthenia gravis related immune checkpoint inhibitor related myasthenia gravis, rituximab is an addition that can be considered for steroid refractory disease. Next slide. And then lastly, we'll talk about cardiac toxicities, and specifically the entity of immune checkpoint inhibitor associated myocarditis. So the incidence of this is actually quite low, less than 1%, but it does account for over 1/5 of annual mortality related to immune checkpoint inhibitor use. So very high mortality associated. These patients require a thorough cardiac workup because immune checkpoint inhibitors can also cause many other cardiac toxicities from pericarditis, arrhythmias, LV dysfunction and heart failure, or even cardiogenic shock. And these patients are at risk of developing heart blocks, so they should ensure that they're monitored in a setting with at least telemetry or cardiac monitoring. In contrast to non-ICI related myocarditis, non-ICI related myocarditis, we will use pulse steroid monotherapy here. And for those who are not responsive to initial steroids, some of the additional immunosuppressants that have been used and recommended in the guidelines are mycophenolate, infliximab, and then also antithymocyte globulin or ATG and abatacept. Next slide. So while treating patients in the acute care setting for immune-related adverse events, it's important to prepare for and consider the possibly life-threatening complications patients can develop from the regimens that are used for treatment themselves, so the high-dose steroids and other immunosuppressants. These are patients who are already immunosuppressed at baseline and can be quite frail. So most frequently reported complications are opportunistic infections. So this includes aspergillus, viral hepatitis, CMV, PJP pneumonia, and the ASCO guidelines do recommend PJP prophylaxis for any patients who are on equivalent of prednisone 20 milligrams daily for at least 4 weeks, which is pretty much any patient with a severe toxicity. And I note here a retrospective study that looked at those patients with advanced stage melanoma on immune checkpoint inhibitors, and they found 13.5% of patients developed severe infections while on steroids or infliximab. So it's a relatively high number. And then we can also consider the other side effects that we can see from immunosuppression from steroids. So that includes hyperglycemia, adrenal insufficiency, osteoporosis. Next slide, please. These are some of the recommendations from guidelines for what to monitor for and assess for in terms of treatment complications while patients are on steroids for immune-related adverse events. Next slide. So now we'll talk a little bit about what is the actual prognosis for these patients, and what have we found in terms of mortality. So overall, immune-related adverse events from immune checkpoint inhibitor therapy have a relatively low mortality rate in comparison to mortality from tumor progression. You can recall the 2017 systematic review meta-analysis that I mentioned earlier. Of the patients that they included, they only found 42 fatal immune-related adverse events, which is 0.6%. However, individual RCTs within that systematic review did report mortality rates as high as 59%. And so it's quite variable. They're most commonly they found was related to ipilimumab colitis. Next slide, please. Here's another systematic review meta-analysis that looked at fatal immune checkpoint inhibitor toxicities. This was published in 2018. You can go to the next slide. Here they reviewed World Health Organization pharmacovigilance data, and they identified over 600 fatal immune checkpoint inhibitor toxicities from 2009 to 2018. The cause of mortality did differ based off of what regimen they were on. 70% of patients receiving CTLA-4 inhibitors died due to colitis, while those on anti-PD-1, PD-L1 related deaths were often due to pneumonitis, 35%, followed by hepatitis and neurotoxicities. In the patients on combination therapy, the high deaths were most commonly due to colitis and myocarditis, and overall across all drug therapies, the highest fatality rate was due to myocarditis. Next slide. And this is from the same study, and we can see the over time increase in fatalities from anti-PD-1, PD-L1, and then less so also from combination therapy, where in contrast, we can see with ipilimumab monotherapy, there seems to be decreasing mortality over time. I think there's a couple of reasons that this may be the case, but most likely it's related to how often we're using these drugs. So ipilimumab monotherapy is becoming much less common, whereas use of anti-PD-1, PD-L1s and combination therapy is becoming much more common. Next slide. And lastly, I include this diagram because it is nice to highlight the comparison between actual frequency of immune-related adverse events and the fatality rate. So on the left in light blue, those bars represent the number of IRAEs that were reported. And then on the right in dark blue, we see the actual fatality rate. And so we can really see the contrast between colitis, which is the most common immune-related adverse event, but in comparison to its frequency has a relatively low fatality rate, whereas myocarditis is quite uncommon and has a very high mortality rate associated with it. Next slide. So the last thing I just wanted to mention was that sort of where the future of research is heading towards, which is looking to identify biomarkers to help us to predict and detect immune-related adverse events and their severity. And so there have been a number of studies. This is one, retrospective analysis of, again, of pharmacovigilance data, but they found most promising were TCR diversity and CD8 T cell abundance, but this is still an area of ongoing research. And so something that we can look towards in the coming years.
Thank you, Laura. So just to finish this off, in terms of when we restart immune checkpoint inhibitor therapy and look at the risks, there was a 2021 meta-analysis of 49 studies that looked at this. And only about 22 of those studies actually looked at progression of disease, but patients who were restarted on treatment had an overall response rate of 21.8% in their malignancy. And the median progression-free survival and median overall survival is noted on the slide. Median overall survival about 15.6 months. And in terms of whether or not they developed another toxicity, about half of the patients developed another toxicity of any grade, whereas about 20% of them developed grade 3 to grade 4. The study authors interestingly noted that they felt that this was not all that different than people who were naive to immune checkpoint inhibitors, and that there wasn't any significant increase, but there's still conflicting data on this, and there needs to be more research on this area. Next slide. So as Laura was mentioning, the ASCO and ESMO guidelines have very specific recommendations that they have around guidelines for what to do with rechallenging. So for grade 4 immune-related adverse events, they recommend permanent discontinuation with the exception of endocrinopathies, which can be managed with oral medications. Grade 3 immune-related adverse events should be a case-by-case basis with consideration of the risks and benefits. Usually if they were on combination therapy, you would de-escalate to monotherapy at that point. but it also depends on how severe and how impactful it was on the patient's quality of life. With grade 1 and 2 immune-related adverse events, it really is dependent on the type of toxicity, but often oncologists will restart these patients on treatment. But certain toxicities like myocarditis or certain debilitating neurologic toxicities often warrant permanent discontinuation. But again, it's a conversation between the patient and their oncologist. Next slide. So just to finish off our presentation, so coming back to our case, the first patient who had metastatic papillary renal cell carcinoma who was diagnosed with immune checkpoint inhibitor-mediated myasthenia gravis, got 1 milligram per kilogram of methylprednisolone and pyridostigmine. And then on the second day of his admission, he received IVIG. He was actually converted to tapering oral prednisolone over the span of 3 weeks and started on mycophenolate mofetil. And after about 3 months of being stable, he was restarted on his just single agent immunotherapy instead of a combination. And he did fairly well for about 12 months before he had tumor progression and was switched to another agent. Next slide. The 83-year-old gentleman who we talked about, who presented with ST elevations and ECG findings that were concerning, went to have an angiogram, which was negative, but a cardiac MRI that demonstrated some evidence of immune checkpoint inhibitor-mediated myocarditis. He received pulse steroids for 3 days, but unfortunately, on the evening of the third day of admission, he had a sudden cardiac arrest without return of spontaneous circulation and died, which is not uncommon in what we see with patients with myocarditis, is a relatively high mortality rate. Next slide. So the take-home messages that I think people who listen to our presentation should take away is that, immune checkpoint inhibitors have really revolutionized cancer care and have led to significant improvements in survival for many different malignancies. There's expanding indications for immune checkpoint inhibitors, and that you will be expected to see them in patients, not just for metastatic disease, but neoadjuvant and adjuvant disease. Moderate to severe immune-related adverse events are not that common, but they can be life-threatening with significant organ dysfunction. And severe immune-related adverse events require inpatient management in high acuity settings. And if a patient is admitted to the ICU, there should be multidisciplinary care between oncologists and subspecialists. And you as a physician taking care of this patient should always have a low threshold to consider immune-related adverse events for patients who are on these drugs. But more importantly, because this is such a new class of medications over the last 10 to 12 years, there needs to be more research done on how we can better take care of these patients when they present to higher acuity, like level 2 or level 3 ICU care. Next slide. So thank you everyone for listening to our presentation. I'd like to say thank you to Dr. Andrew Chung for acting as our faculty supervisor, and we'd be happy to take any questions at this point in time.
Fantastic. Thank you all for an excellent presentation that covered a lot of ground. Very important topic that hits on all specialties and subspecialties. So we do have one question in the Q&A, and I'll invite anyone else who does have questions to please feel free to add those into the Q&A section or raise your hand if you prefer to ask your question verbally. So the first question here is, patients started on checkpoint inhibitors. How do you determine the duration of therapy, and when are they on indefinite therapies? And I'll leave it to the group of you to determine. I know Arman's headed for a career in oncology. I see he's unmuted, so over to you.
So thank you for that question, Dr. Kurnu. So in general, it depends on the study protocol. If it's being used in more of the adjuvant study, it could be anywhere between 6 months to a year. Generally, what I've seen in my time in the clinics, these medications in the metastatic disease are pretty much used until they don't work. There are some patients who continue to have benefit even like 5 years out. And typically what I've seen is about after 12 to 24 months, then there's a discussion had between the oncologist and the patient to maybe do it every other month or even just stop and monitor. And to that point, what I will say is that some patients who develop toxicities and they end up in the ICU, for example, hepatitis, and their drug is stopped, some patients will actually continue to have benefit from drug, even if it's they stop the drug for months thereafter, because there's ongoing inflammation, there's ongoing kind of PD-1, PD-L1 interaction. So it's a case-by-case basis, but it's specific to the malignancy and specific to the protocol. So that'd be a question you should double check with the oncologist if they are admitted under your care. And then the next question around COVID infection, how this does COVID increase toxicities of these drugs? I'm not sure if we know that specifically. There might be an increasing risk of pneumonitis, but that's something I would have to probably look at the guidelines a bit more, but I'm happy to let my colleagues answer that if they have questions around it.
Maybe I'll just read out the question because I don't think the audience can see the question. Patients who get COVID infections, how does this play out in the long run? Does COVID increase toxicities of these drugs?
Yeah, so when people have COVID infections, we do cancel therapy until their acute COVID infection is resolved, and then they thereafter are restarted on treatment. I'd have to look at the literature. I'm not 100% sure whether or not COVID does increase toxicity of these drugs. I would imagine because it's quite a pro-inflammatory state, we would want to wait until patients are completely asymptomatic. But whether or not people who have, for example, long COVID or those symptoms, I think that has to be further teased out.
Excellent. Yeah, I'll just welcome Drs. Gerber and Spatafora to chime in if they wish. I've got a question, and I'm looking at it from the patient consenting process or patient kind of explanation in the clinic, right? So these are really high stakes situations, patients with oncology diagnoses, often metastatic. And I'm just wondering if any of you can comment on what you think a best approach to informed consent for patients is when there's such a wide range of complications that can be happening. These are obviously drugs that work very well. What does the tone of that conversation look like in its best form, do you think?
So maybe I'll chime on that because I've seen a lot of these conversations myself. The thing is, most patients are not aware of what immune checkpoint inhibitors are when they come to any cancer clinic. They're very aware of side effects from chemotherapy, but not immune checkpoint inhibitors. So often what we say to patients is the side effects you get from chemotherapy and immunotherapy are very different. You're not going to get nauseous, you're not vomiting. But because there's such a wide variety of things that can happen, I like one approach that Dr. Tozer, who's one of the oncologists at the Gerber Cancer Center, mentioned, which is you tell patients anything that ends in the word itis, meaning causing inflammation, can happen with your immune checkpoint inhibitor. And that could be colitis, dermatitis, hypophysitis, you name it, it can happen. The other thing we do reassure most patients is, as the studies have shown, while you will probably, especially if you're on combination therapy, you will likely at some point, especially at the 4th or 5th cycle, develop some sort of toxicity. The hope is that it's something like dermatitis or very mild colitis that we can go right through. But it is possible that you develop something more significant. And these are the specific toxicities that are more serious and you need to let us know about. And we also talk to patients that we're going to be monitoring LFTs. If you develop dyspnea or chest pain, these are things they need to be aware of because it could be a sign of inflammation. Generally speaking, because the actual efficacy of these drugs are so good, and patients want something, and it really helps to preserve quality of life compared to chemotherapy, which often causes more nausea, vomiting, and their quality of life is poorer for those every 3-week regimens they have. I find patients are happy to understand all that and they do consent. But I've actually recently been working on a study to look at how many patients develop those chronic IRAEs, so more than 12 weeks. And I think there's more research going on about the chronic IRAEs so that we can help inform patients a bit better, because that's an area that's still undergoing research, so we can just better have informed discussions with our patients.
Excellent, thank you. I like that framing of things, and just, obviously having to be upfront with patients, but it's so hard when there's a high degree of uncertainty about whether or what type of complications may result from the medication. Great, so there's a couple more comments and questions here popping into the chat. A comment from Dr. Curnew following your responses to his questions, great rounds. So thank you for that feedback, Dr. Curnew. From Dr. Mitch Levine, it seems that ICI are not used in GI cancers. Any reason?
So they are used in GI cancer. So actually there were some studies about it being used in the, I think it was in the metastatic setting in patients who have squamous cell cancers of GI origin, so like esophageal cancers. And they actually are used in metastatic colorectal cancer, but patients who have a mismatched mutation, like a mismatched mutation repair genome, And actually, there's more evidence for them being used even in the upfront setting. So we do use them in colorectal cancer. I didn't stress it too much just because the predominant indications that they were initially used were for melanoma and non-small cell lung cancer, as well as renal cell cancer. But we definitely do see it used in colorectal cancer. It just wasn't highlighted in our rounds today.
Okay, and there's, thank you for that. So there's one more question from Dr. Curnew. What are the costs of these drugs?
So very expensive. I don't know off the top of my head, but you're looking at something around, I think, anywhere between 10 to 40,000 a month. So very expensive drugs. These are all approved by Cancer Care Ontario, and funding is through Cancer Care Ontario. Some patients actually are willing to pay for them at private infusion clinics if they're interested, but generally, because the cost is so prohibitive, the only way you get actual approval for these medications if it's approved through a regimen through Cancer Care Ontario. And Cancer Care Ontario is pretty good with as soon as the trials come out and if there's a signal towards it, there's a review process that happens. And I think most patients receive it that way. But there's also a lot of clinical trials that run out of the JCC and Princess Margaret as well. And a lot of patients are actually offered it upfront as part of a clinical trial. So I haven't found it to be significantly prohibitive for most patients.
Excellent. Thank you so much again for an outstanding presentation and a really engaging Q&A session. So thanks to Drs. Gerber, Spatafora, and Zereshkian, and also to Dr. Wynn for co-hosting today. And thanks to all our attendees and those who brought forward their questions. This will be wrapping up our session for today. Next week will be medical grand rounds hosted out of HHS. And it will be Drs. Legault and Pereira providing their presentation. And then following that, on April 13th, we have again an HHS hosted rounds, Dr. Hugh Truckware from GIM. So wishing you all a fantastic day, rest of your day, and see you back next week for rounds. Take care.